without further ado, it is my pleasure to introduce today's first speaker, Scott Morano, Senior Vice President with Ipsos Healthcare. Scott, you have the floor.
Thanks, Megan. I'm going to turn off my webcam now just because I don't want it to crash my computer if something happens with the internet speed. So I'd like to start with a brief recap of our methodology. In partnership with M360 Research, we interviewed 550 US physicians across 11 specialties. We also interviewed 2,100 patients across the United States. The online interviews were conducted from January 28th through February 8th, and our screening criteria was fairly open. The HCPs had to have 75% of their professional time in patient care before COVID, and they have to still be treating patients now. On the patient side, we talked to people age 18 to 74, and the only requirement was that they had to have at least one doctor appointment in the past year, not counting emergency or urgent care. Both surveys focused primarily on their experiences with telemedicine. In addition, we conducted qualitative interviews with 10 payers across the US from January 12th through February 3rd. We carefully selected payers from large national plans, regional plans, and IDNs with a goal of getting a healthy mix of representation across commercial, Medicare, and Medicaid beneficiaries. The objective of these discussions was to understand how current telehealth utilization and concerns impact future coverage and reimbursement. So today for our agenda items, we'll take you through current telemedicine usage, the satisfaction with telemedicine, reimbursement situations, the future for telemedicine, and how pharma companies can help. We'd like to start with highlighting how telemedicine is currently being used. The pandemic necessitated a push to increased usage of telemedicine across the entire healthcare system last year. Now that we're 1 year into the pandemic, we wanted to understand how telemedicine is currently being used. Telemedicine usage has declined over the course of the past several months, with HCPs indicating 32% of their current appointments are conducted through telemedicine. This is lower than the mid-pandemic peak, but still much higher than pre-pandemic levels. We're highlighting the tops and the bottoms among the specialties. Psychs are the specialty continuing to adopt telemedicine at extremely high levels, and neuros are the second highest, even though they use telemedicine at only half the level of psychs. Cards and derms are the specialties least likely to be using telemedicine right now. When we turn to how patients experience telemedicine, they report the same level of usage as HCPs, with 34% of their appointments over the past year reported to be via telemedicine. Among the conditions we found among our sample, patients with bipolar and depression treated by psychs and migraine treated by neuros are the conditions most likely treated via telemedicine. But not every physician and patient has embraced telemedicine. 32% of HCPs and 44% of patients report no telemedicine appointments. We were curious about how patients are funneled to telemedicine versus in-person appointments. This question highlights one of the biggest disconnects we saw between HCPs and patients. HCPs believe the patient is the one deciding to conduct the appointment over telemedicine for a majority of those appointments. Patients, on the other hand, believe the physician is the one deciding to have the appointment over telemedicine. So what's the true story? Our hypothesis is that physicians aren't necessarily aware of how patient appointments are scheduled, so they assume if they didn't specifically ask the patient to be seen over telemedicine, then it must be the patient's choice. But from a patient perspective, if telemedicine is offered to them by the scheduler, they might be interpreting that to mean the physician is deciding for them, even if it might ultimately be their own decision. Going forward, HCPs and their staffs should be cognizant of helping patients identify when the appointment is appropriate for telemedicine, and we'll see this theme highlighted later in the presentation. Looking at the platforms available for telemedicine, there is no one clear platform that's being widely adopted right now. From both patient and physician perspectives, telemedicine is perhaps more likely to be delivered with a simple phone call, but equally likely to be delivered over a commercial platform such as FaceTime or Zoom, or delivered through a specialized healthcare platform designed for telemedicine, We actually found that a lot of the HCPs and patients had used multiple platforms over the course of telemedicine, meaning there really is quite a big mix and a lot of different technologies and platforms that people need to navigate when considering telemedicine. When we look at satisfaction with those platforms, patients are equally satisfied with all of these platforms, but HCPs are particularly less satisfied with telemedicine conducted only over the phone. I'd like to turn to my colleague, Fanon, to discuss payer perspectives of telemedicine platforms.
Thanks, Scott. So we have to remember that during the peak of shutdowns, the healthcare system as a whole was trying to curb revenue loss wherever they could. So that came in the form of basically removing all barriers to telehealth. That meant that video chat platforms that most patients were already comfortable with, such as FaceTime and WhatsApp, were allowed by at least 7 out of 10 payers that we talked to, despite not being HIPAA compliant. Those plans who did not allow for that had the necessary IT infrastructure, such as patient portals with video capabilities, in place prior to the pandemic. However, going forward, payers indicated that they will not be supporting that due to security concerns. So one payer actually cited national news stories of Zoom calls being hacked. And then this payer even went as far as to say, quote, "We did not pay for visits conducted on non-HIPAA compliant platforms prior to COVID. I believe it should be a secure video-based platform." Frankly, there's some argument from people on our plan that we should continue to allow phone calls because our older members or our poorer members may not have access to video devices. But we've done research before, and close to 100% of our Medicaid membership had cell phones. So that's somewhat of a quick canard. So payers at the moment, in this space really aren't accepting any counter arguments to using non-HIPAA compliant platforms, not even from an access standpoint.
Thanks so much, Fanon. That's really interesting about the HIPAA compliance piece in particular. So we just looked at satisfaction with the specific telemedicine platforms, and now we'd like to broaden out to look at satisfaction with telemedicine as a whole. Now that we've had a year to experience telemedicine at these advanced levels, we can understand from a multi-stakeholder perspective what is working well and what isn't. Among HCPs, psychs, who are the most energetic adopters of telemedicine, they're the only ones that are truly satisfied with telemedicine. Among all HCPs, only 30% are very satisfied, with cards and rooms among the least satisfied with telemedicine. Patients are more satisfied with telemedicine than HCPs are, with 60% of patients reporting being very satisfied. We asked the HCPs what they thought patient satisfaction was, and they suspected patients were having more satisfactory experiences than they were, but they still underestimate by quite a bit how much more favorable patients really are towards telemedicine. If we turn to potential pain points with telemedicine, we see HCPs find some of their regular activities to be made much more difficult over telemedicine. HCPs, especially those in primary care, believe telemedicine makes it much harder to develop relationships with new patients and to diagnose patients with new conditions. HCPs also find it difficult to start a new patient on new therapies. We're showing psychs on this slide because they're not really experiencing these challenges to the same levels as their peer groups. Conversely, patients aren't experiencing these same types of pain points. Among patients who have been treated by the same doctor both in person and with telemedicine, nearly half believe telemedicine helped them to develop better relationships with that doctor. To some extent, this might be what we used to call the Zoom effect at this time last year, where because they're seeing the doctor at home rather than in the office, they feel like they're getting to know that doctor more as a person. Or perhaps the experience of telemedicine feels less clinical to a patient when they can be treated while they themselves are at home rather than in an office. But beyond the relationship, patients also believe telemedicine makes it easier for them to schedule appointments, get prescriptions, and even ask follow-up questions. Turning back to HCPs, we've really only focused on the tops and bottoms among the 11 specialties we interviewed. But we'd like to share this perceptual map that really helps explain how different specialties are experiencing telemedicine, and what the benefits are and what challenges that they currently face. So looking at psychs and endos, these are generally the most favorable towards telemedicine. These are the specialties that are most likely to see the benefits telemedicine provides to their own practices in terms of increased flexibility, efficiency, and profitability. If we look at allergists, gastros, infectious disease specialists, and neuros, they're slightly less favorable than psychs and endos. They believe telemedicine provides benefits to patients in terms of flexibility and cost savings, but they also are starting to have concerns about the scheduling issues telemedicine can create for them. Cards and oncologists in particular do see some of the benefits telemedicine brings to their practices, but they're more concerned about the challenges they face monitoring patients for side effects and for tolerability issues. And they also don't believe telemedicine provides the same benefits to patients that the allergists and gastros observe. Among the specialties we talk to, derms and rheums tend to be the HCPs that are most hands-on with their patients, and as such, they're the most negative toward telemedicine. They believe success for telemedicine requires the patient to self-triage when telemedicine is appropriate, and it's clear they don't believe patients can make those decisions. They are also facing billing issues due to telemedicine, and they're the least likely to believe telemedicine provides any benefit to their practices. Lastly, we come to primary care. While the derms and rheums are concerned that patients are struggling to self-triage for telemedicine, the PCPs themselves are struggling to identify when patients are good candidates for telemedicine. They're also concerned about monitoring side effects, and they struggle to appreciate any efficiency or flexibility for themselves or for their patients. And Phenom will now talk about some of the pain points that payers are experiencing with telemedicine.
So payers expressed several frustrations with the adjustment to higher telehealth utilization. The first pain point was waiving copays. So we found that 9 out of 10 plans completely waived patient copays, while one had reduced patient copays by about 50%. We framed this as a short-term issue because it was a temporary measure meant to maximize access for patients while offices were closed. But as some payers elaborated on, it's obviously not sustainable. And in fact, we've actually begun to see some payers revert back to charging full copays for telehealth just at the start of this year in 2021. So when it came to waiving patient copays, one payer actually commented that, quote, "From copay loss alone, we lost $14 million on telehealth because the CMS reimbursement assumed a patient cost share. And if patients did not have the cost share, then we had to dig into that pool of money and pay for telehealth. So telehealth was a money loser for us." And then from a longer term perspective, we heard a surprising amount of concern around the issue of abuse and fraudulent coding of services, or I should say billing. Several payers spoke to the fact that most physicians make the bulk of their revenue from added services after seeing the patient in person, such as, labs or exams. But without that option, it was a bit lucrative to try and bill for as many things in one visit as possible to make up for lost revenue. So physicians during this time were also not held to the same standards of documenting throughout this period. However, going forward, plans will require official documentation to qualify for reimbursement, which actually might make telehealth appointments just as time-consuming as in-person visits. And to that point, one payer actually commented, quote, "We know that there's been issues of fraud and abuse. We know there's been issues of upcoding in the more recent environment. We've audited it. I suspect we've investigated some providers. They don't tend to be at the fancy medical school. They tend to be more rehabilitation providers and what have you, but I'm not going to contend that it never happens or has never happened."
Thanks, Fanon. And sticking to the financial themes, we'd like to explore the reimbursements for telemedicine. HCPs right now generally believe they're currently being reimbursed at roughly 75% of the amount of in-person visits. Few of the HCPs, only 27%, reported receiving 100% reimbursement at present for telemedicine. If we look forward, HCPs are anticipating lower reimbursements for telemedicine. On average, they would consider abandoning telemedicine altogether if the reimbursements drop to 60% of in-person reimbursements. It's also important to note that 32% of HCPs claim they will always offer telemedicine, regardless of the decline in reimbursements. Phenom will now talk at more depth about what payers are likely to do regarding those reimbursement levels.
Yeah. So when it comes to reimbursement, physicians will most likely be reimbursed at around 60 to 80% of the cost of in-person visits, and patients can expect their copays to revert back to in-person rates. And that does align with the lowest rate that providers are willing to accept, like Scott just mentioned. But then you have to factor in the fact that HCPs don't believe that they're being reimbursed at 100% today. So when you step back and you really think about the fact that providers won't be making as much on telehealth visits as they are today, and then you layer on that they already perceive that amount to be less than 100%, then you tack on the fact that patients will be expected to pay the same co-payments, but without all the elements that make it a complete visit, like a blood pressure screening or other exams as well. It becomes kind of like a laundry list of reasons that might disincentivize patients and providers from using the service at all. So one payer kind of even doubled down on the rationale for that rate, for that 60 to 80%, saying, quote, well, the reason we won't reimburse at 100% of an in-person visit is because nobody's going to believe in the health plan world that a telehealth visit is worth the same as an in-person visit. They don't have the overhead.
Thanks, Fanon. We'll now turn to how telemedicine is likely to be deployed at a time when COVID vaccines are widely distributed and normalcy returns, knock on wood. And especially in light of what Fanon was just mentioning about the reimbursements, with the rate going down with patients being expected to have copays, would we really like to understand how telemedicine will be used in that kind of a future. HCPs do also believe that telemedicine usage will decrease post-vaccinations, but with roughly 1/5 of appointments expected to be over telemedicine, we believe it will continue forward at a higher level than telemedicine was used before the pandemic. The psychs have the highest anticipated post-pandemic usage, but even they anticipate a 50% reduction from their current levels. Knowing that telemedicine will play a not insignificant role in the healthcare system going forward, we wanted to understand how HCPs and payers would identify the optimal scenarios for telemedicine. Among HCPs, we explored 3 ways they might qualify patients as good candidates for telemedicine. Starting with disease severity, we found HCPs are only likely to recommend telemedicine for patients suffering from a mild disease. The more severe the patient is, the less likely HCPs would recommend telemedicine for that patient. We also wanted to explore if patient age would be a factor and why HCPs might funnel someone toward telemedicine. We find that doesn't really appear to be that significant a factor. They're most likely to recommend telemedicine for younger adults age 18 to 34 and for those age 35 to 54, which might support the idea that telemedicine requires a certain amount of technological proficiency among patients. But it really appears that age on its own wouldn't be the primary lens through which HCPs evaluate patients as appropriate for telemedicine. We also took a look at the type of appointment to see if that might be a way that physicians might look at where telemedicine is appropriate. And what we found is that HCPs believe that more regular routine appointments like a checkup or follow-up visit would be the most appropriate type of appointment for telemedicine. Any kind of appointments for new patients, for diagnosing new ailments, or even new starts are not likely to be recommended to patients for telemedicine. So the optimal scenarios from an HCP perspective are likely a combination of mild patients that are having regular non-diagnostic appointments. Fanon will now address how patients are thinking about deploying telemedicine in the future.
Yep. So among payers, we explore 2 ways to categorize a telemedicine patient of the future. The first being by practice type and the second by appointment type. So at the practice level, behavioral and mental health is one area where telehealth works particularly well, and is pretty much here to stay. And that kind of lined up with how psychiatrists rated and plan to use telemedicine. There was similar feedback about primary care, but mostly because they could use telehealth to refer certain chief complaints to a specialist. Remember, that's a payer's perspective. And so when we look at the research that Scott did, we saw that PCPs don't actually prefer to use telemedicine going forward. So one payer elaborated on how there was an increase in telehealth for behavioral and mental health, saying we covered behavioral health. And in fact, that's where we saw the biggest uptick was in the behavioral health visits that were telehealth in lieu of in-person. Behavioral health was about 2 to 1 greater than medical. And if we look at use cases that almost every therapy area can take advantage of, it's chronic care management through follow-ups. So one payer even suggested that it offers efficiency because before COVID, the time span between appointments could be weeks or months. So then providers would get phone calls with random questions, but telehealth helps to alleviate some of that. As one payer said, quote, I think for a lot of specialties, it works well for follow-up. So I think it will become more routine to have the question of, do you want your follow-up as a telemedicine or an in-person? There's not a lot of content to them. So a lot of complaints about members that can't reach physicians for questions or phone calls can be made billable by turning them into telehealth visits. So really all of these factors that I've mentioned throughout, like IT security, abuse and fraud with regard to billing codes, and appropriate patient segments for telehealth are factors that payers are thinking about when envisioning how they're going to write medical policy for this, and frankly, restrict telehealth utilization in the future.
Thank you, Fanon. Lastly, would like to look at what the implications are for pharma companies with respect to telemedicine. So while most patients are treated the same, whether seen in person or over telemedicine, we do find 1/4 of patients received a different treatment decision specifically because their appointment was over telemedicine. And we're seeing that primarily with the DERMS cards and PCPs. The biggest reason for that isn't really a surprise. It's that any treatment that requires some type of in-person component, whether it's diagnostic testing, monitoring, or administration, whether that's an in-office prefilled syringe or infusion, these are the most likely treatments that are being impacted by telemedicine. And again, it's especially true for DERMS and PCPs. Looking at script writing, we've heard anecdotally that the pandemic has created a scenario where HCPs and payers are encouraging more long-term refills. At this point, we're not seeing telemedicine alone as a key driver of 90-day scripts or multiple refills. HCPs tell us they're essentially equally likely to write long-term scripts for patients treated in person or over telemedicine. When it comes to what kind of support specifically pharma companies can provide to HCPs with respect to telemedicine, the HCPs are not dissatisfied with what pharma is doing, but there's definitely room for some improvement, especially in terms of any kind of materials that can be readily shared with patients when those patients are not physically present in the office. So, for example, any kind of patient support program, sample plans, digital brochures, videos, these are the kinds of things where there's not a ton of dissatisfaction, but we're finding, very few HCPs saying they're very satisfied, and that's top 3 box on a 7-point scale with how pharma is currently supporting them. We did ask HCPs on an unaided basis, what are some things that pharma companies can do to assist you in treating patients over telemedicine? And by far the most common response among 25% of the physicians we talked to was something related to samples. We've got some of their verbatim comments here, but some of the ideas that they mentioned included digital vouchers of some kind that patients could redeem at pharmacies. Many of them mentioned some way to directly send samples to patients, whether that would be coming from the pharma company itself or whether it's something the physician could do to send out, but some way to get samples directly into patients' hands when they're not coming into the office. And we looked at how new starts are certainly difficult to conduct over telemedicine, and this could be a key way for pharma companies to reduce barriers to prescribing new treatments to telemedicine patients. So in conclusion, we're really seeing that telemedicine usage will continue to decline as our society returns to a more normal state. But we do believe telemedicine will be present at higher levels than pre-pandemic. We believe it will be more targeted going forward, so likely for milder patients and routine appointments, and likely limited to the specialties where telemedicine seems to be the most appropriate, such as psychiatry and behavioral health. And there is that inclination, Fanon mentioned, among payers to provide telemedicine access in primary care, but PCPs in particular will really need guidance about how to best deploy telemedicine in their practices. And lastly, pharma companies can best support HCPs in telemedicine by deploying more digital-first patient support programs, including samples for those patients that are treated via telemedicine. We also believe HCPs and primary care in particular could benefit from some help from pharma companies in understanding the new patient journey in a telemedicine environment, how to triage patients that are appropriate for telemedicine, and the kinds of support and services that can be provided to really enhance that telemedicine treatment experience. Thank you all so much for joining us today. We'd like to open it up for questions, and I'll pass it back over to Fanon to take a look at what some of you are asking.
Thanks, Scott. So I think we do have a few questions from the audience. Scrolling through here. So the first one reads, why don't payers want HCPs to use telehealth in the future? So good question. I think there is still this resistance from a payer perspective, because generally speaking, they don't think patients are getting optimal care through telehealth. If patients aren't getting optimal care, then they don't see the value in it for most patient-provider engagements, especially when patients aren't receiving the full gamut of services like they normally do. So like I mentioned, the blood pressure screenings, or even having other labs and tests completed and interpreted in real time in the same visit. So, you know, there are some people that go to the physician's office and there's a scanning that can be done in the same visit, and then, you know, you're there for 2 hours, but at least you get everything that you need at once. And telehealth it doesn't allow for that. And so I think payers are looking for more of that engagement, because they think that directly translates into better patient outcomes. And that's, you know, that's a fair perspective to have. Looking at another one that says, why is there a discrepancy in payers claiming to pay providers at 100% and physicians claiming that they are only receiving a fraction of that? That's a good question. It's a little complex. So we've discussed this internally, and we think that the discrepancy is primarily coming from low volume. We've heard from payers before, more so in the argument for capitated payment models and such, that physicians don't make great accountants. And that's not a ding on them, you know, because managing the finances of a practice is difficult and complex on its own, on top of, you know, having to basically lead clinical care. We just think that there is some confusion on where exactly the revenue loss is coming from, and that it's being incorrectly attributed to lower reimbursement rates as opposed to fewer billable activities. So I hope that answers your question. Let's see here. Okay, so I think this one is one for Scott. It says, did we see anything in the data that suggests telemedicine usage or satisfaction is higher among younger people?
Oh, that's an interesting question. I think, you know, going in, our hypothesis would have been that telemedicine usage adoption satisfaction would likely be higher among younger patients and lower among the older patients. What we saw among HCPs those that were in practice for less than 10 years, and so that would be a younger cohort in theory, they were the most satisfied with telemedicine, but it really leveled off after that, and it wasn't a great amount of higher satisfaction. It was maybe 6 or 7 points higher. Among patients, the younger cohort, so the age 18 to 34, they're actually the least satisfied with telemedicine on a directional basis. And we think that's actually because the younger folks probably have higher expectations for the platforms. So instead of comparing a telemedicine appointment to a regular in-person doctor appointment, they're comparing what's essentially for them a Zoom meeting with any other Zoom meetings that they have in their lives. So the clunkiness, awkwardness of a telemedicine experience is probably going to be not rated as highly as the kinds of telemedicine, like web video meeting experiences that they're having in their day-to-day lives. And so there's probably just a different lens that they're comparing that to, and so finding it lacking. But again, that's our hypothesis based on the data that we're seeing that suggests that they're kind of grading the telemedicine on a harsher curve than older patients are.
Interesting. Let's see here. I have another one that I think Scott would be better suited to answer. So the question reads, after COVID, will patients continue to request telemedicine appointments?
Oh, that's a good question. I don't think we covered that one in here. We covered that we think physicians will expect there to be more telemedicine appointments, and that payers will certainly suggest some instances where telemedicine is appropriate. But we didn't cover the patient perspective. We did ask that in our surveys. Most of the patients who chose a telemedicine appointment noted that they chose that route due to safety and COVID-related reasons. And so I think that tracks with what our hypotheses might be about why there was so much uptake of telemedicine over the past year. But we did see around 20% of those patients noting that they selected telemedicine because it was more convenient or a more time-efficient option. With both physicians and patients, they were noting that telemedicine appointments are around 10 minutes shorter on average than in-person appointments. The patients certainly experience those appointments longer than the physicians do by about 10 minutes, but overall, it certainly is a shorter appointment. And so we do see the patients saying that they picked telemedicine so it would be more convenient for them. And we anticipate those reasons will still apply post-COVID. And if we think maybe 20% of patients are thinking telemedicine is more convenient, more appropriate, that actually tracks with where HCPs themselves expect telemedicine usage would shake out. So I think there would be scenarios where patients would be interested in telemedicine post-COVID just because of that convenience factor. Fanon, do we have any other questions that are in?
Nope, that was it.
All right, Megan, I think that's all that we had for today.
Great. Thanks so much to the both of you for your interesting presentation today. And thank you everyone for joining us as well. And if we didn't get to your questions, then we will do so by email. You will also receive an email with a direct link to today's recorded presentation. And of course, we welcome the opportunity to speak with you, so please feel free to reach out to us. That now concludes today's webinar. Have a wonderful day.